Yeah, good evening, Dr. Brown, and thank you for making the time from me with your busy schedule to share your thoughts with us on this podcast, especially discussing economic impact of oral health on patient well-being. Just briefly, I want to tell the people who are listening how we met. I have met you actually as a student at this stage in my life, and I'm very happy to have met you as a student during my dual MS that I'm doing, MBA and Masters in Healthcare Leadership at Cornell, and you are one of the professors that really stimulate me about talking economics in healthcare and what are the issues of it. And because of you, I've had this idea to come up with the series of three. Just for the people that don't know you have a PhD in healthcare policy and research with concentration in health economics, which makes you an expert on the economics of healthcare. You recently testified as an expert at the US Congress, and it's actually one of the topics that we're going to be touching on, which is the medical corporations. And this is not your first time to testify before the Congress. With that said, I can't interview a better suited person to discuss the economic impact of oral healthcare, which is part of the healthcare, under the umbrella of the healthcare on the well-being of the citizens of this country. So with that said, let me start with the first question. One of the things that really struck me when I was taking your course is you talked and you introduced us all to the iron triangle. And iron triangle, people probably think it's a triangle from iron, but it is a very heavy iron because this is how the healthcare is being conducted right now. And I would like you to introduce it briefly for the people that are listening, and they understand how people are assessing the outcome of healthcare in the United States.
Well, Gertie, before we get started, thanks for having me. I really appreciate it. And it was great having you in class. You're always engaging in interesting and great points of view. Just getting into the iron triangle, just summarizing what it is, right? It's kind of a conceptual thing where it encompasses three crucial dimensions, or think of three angles within a triangle, right? There's access, cost, and quality, right? Think of this triangle where each corner represents one of these dimensions. And the ultimate goal here is to achieve a balance among the three in the context of healthcare. So what do I mean by access, right? This refers to the ease in which individuals or patients can obtain needed medical services. And I want to emphasize needed medical services, right? Cost represents the expenses associated with healthcare. Now, this can be both at the patient or individual level, as well as the system level, right? And system can mean a lot of things. It can mean the county, it could be a health system, it could be a corporation, right? It can be applied to all different types of system levels, all right? And then quality, right? This pertains to the standard of care received, essentially how good or bad or effective the care is. So if we were to kind of steer this to oral healthcare, right? Oral health, I'm not an expert in oral health. You are, so you can probably elaborate on that a little more. It can be viewed as intrinsically linked to overall health, right? So let's say that in this iron triangle and the context of oral health, we want to improve its access, right? If we can ensure, more people have access to oral healthcare services, it can prevent more complex and expansive treatments in the future, right? And for instance, regular dental checkups can catch and address issues before they become a major health complication for that patient, right? And with access to oral health, the hope is that we reduce costs, right? And so by providing preventative oral care, we can potentially reduce the occurrence of severe dental issues that demand costly treatments. right?
Correct.
And furthermore, good oral health can prevent other health complications, leading to savings in overall healthcare costs, right? It can have downstream effects to actually lowering healthcare costs. Now, the other component to that, right, leads us to enhancing quality, right? Oral health contributes to the overall well-being,
Correct.
right? And by enhancing the quality of oral care, we can improve individuals' quality of life, reduce pain and suffering, and prevent systematic issues linked to oral disease, such as heart disease, right? So if you're going to take anything from this long spiel, right, the iron triangle in health economics is premised on the idea that there are inherent trade-offs. I talked about this a lot in my class
Correct.
about trade-offs, right? Among these three vertices or dimensions, or the angles of the triangle, right, of access, cost, and quality. So if policymakers or healthcare administrators or people making decisions in your corporation or organization want to improve one angle, there might be ramifications on the other two.
Correct.
Right? When you increase access, that could lead to unintended consequences, right? Now, Edgar, do you want me to go through those trade-offs, or do you want to kind of?
Yeah, but see, let's talk about those things, because this is very important. It encompasses everything. And I tell you, as a layperson before taking your course, we did not understand that governments or bodies that govern us, whichever way where they look at these outcomes. How can we reduce the cost of treatment? So that is the point that is very important that you brought up. Taking oral health care seriously from the physicians as a comorbidity, we heard about this word so much during COVID, can reduce an additive chronic disease to the patients. And with that, it will improve their home care, their well-being, and then it will reduce the cost on the government in general. So you touch on something, you couldn't have put it better than that. And with that, definitely there is trade-offs. So the trade-offs that you are discussing about, we don't have to go into a lot of them, but people have to understand, because this is an opportunity for everybody to understand why we are in such a bad place in healthcare. So please just explain it to them, in your own way. And what are the trade-offs?
Right. So we have, as an organization, even on the system level, like the healthcare system level, we have a fixed amount of resources, right? And those resources have to be distributed one way or the other. And some have to be allocated more in certain angles, but the idea here is to make a perfect balance, to make an equilateral triangle. In reality, that doesn't really take place. So let's say that we want to increase access, right? It's a really good thing, and that's what you hear a lot of people talk about. But because we have a fixed amount of resources, be it on the system or organizational level, right, there's going to be a trade-off with cost or possible trade-offs with quality, right? So if we increase access to a population of people that might have not otherwise had access to oral care, right, we could conceivably be making healthcare more accessible, but it means opening up more clinics, training more personnel, or subsidizing care for more individuals. This can lead to increased overall healthcare expenditures, right? And the trade-off with quality is, well, because we've generated more access to individuals and we rapidly expand that access, we might put a strain on the existing healthcare resources, which could lead to rushed training of healthcare professionals.
Correct.
It could lead to longer waiting times to get care, right? Which could ultimately or potentially reduce quality care, right? Now, let's say that we want to reduce cost, right? There's a trade-off with this access, right? There could be situations where there's cost-cutting measures, which might lead to the closure of some facilities, right? Or these longer waiting times, or reduced hours of operation, right? Making healthcare less accessible for certain populations or in specific geographic regions. I've talked to you a lot in class about how healthcare is local. All of
Correct.
these things stem at the local level, right? And then trade-offs with quality, right? When you're trying to reduce cost, right? There could be cost cutting that might also involve using cheaper medical supplies, less trained staff, or not adopting the latest and sometimes more expensive medical technologies or procedures. And this could lead to lower quality of care. But then, right, the other part of this is if we're going to try to increase quality, right, you're going to have trade-offs with access and cost, right? So if you increase quality, right, the trade-off with access is you're focusing on high quality care might mean concentrating resources in specialized centers or on specific treatments, which could make them less accessible to the broader population.
Perfect.
And the trade-off for cost could be, improving quality might entail adopting the latest medical technologies, best practices, or higher training standards. While these can provide better care, they often come at a higher cost, right? So all of these things are interrelated. There's no single dimension that's right, but as an organization or a system level, you have to figure out what is the optimal way. And that's the $1,000,000 question, right? And that's what's really, really hard about healthcare in the United States.
And I'm mesmerized listening to it. This is not my first time hearing it from you, but really getting again because it has a big impact. I'm in my 50s right now, so I start thinking about also my care and also for my patients that they are aging, and we're going to talk about that in a bit. That's another point that you are very specialized in it, which is the aging population. So we talked about the iron triangle. We talked about the outcome of the healthcare, how's the impacts, the trade-offs, accessibility, all this good stuff, quality and the cost. So moving along with that, there is an impact on the patient care, which you beautifully discussed. There has been an increase in medical corporations. And that is something you testified in the Congress about. And just for the listeners to tell them briefly what we are talking about, in dentistry, we call them DSOs, Dental Service Organization. In medicine is MSO, Medical Service Organization. Basically, they are a conduit for investors to have a ownership on medical or dental practices, yet locally, as you mentioned, locally, every state, usually the dentist or the doctor have to have the license in order to have a practice. So they created this entity in order for the VCs of the world or the investors of the world to have access to that and ownership. You are an expert on that. So why don't we because that's very important. I cannot tell you how important, because this has changed the whole medical. Obviously, you know that, but it's changing the dentistry, So can you tell them how it happened, why we are where we are, and then we will talk a little bit about why it's growing to that level.
Right. So it's very multifaceted. It's not one single thing, but in class, I always talked about how there are these things called merger waves, right? And history always repeats itself. Healthcare is not independent of that. And because of business cycles, right, we go through these long merger waves. Where we currently are in one. Where we've seen this flurry of mergers and acquisitions taking place, right? But they mainly happen for a couple main reasons. First is a technological advance, right? Technology improves quality of care, right? There are new ways of improving quality of care. Providers change their behavior, right? So that brings in an influx of interested investors to come in and make acquisitions. The second is economic expansions, right? We, for the longest time, up until COVID and then, briefly We had a scare economically, but after COVID had an increase in economic expansion as well. This is due to low interest rates. So organizations could go around, borrow cheap debt, and make acquisitions. So during this time, they used that cheap debt to go and acquire physician practices, dental practices, or whatever. And so during that time, what they typically do is they acquire a large platform organization, or a large DSO or MSO that's well regarded in the community. And they use that large organization to go and acquire smaller organizations or smaller dental practices and roll them up into the big practice, right? And this is, not getting into the nitty gritty. This is called an arbitrage play, where you buy the large platform at a large multiple of EBITDA, which is essentially a proxy for cash flow, usually at 8 to 12 times multiple of EBITDA. And then they acquire the smaller one around, a multiple of 3 to 5. And then when they roll it up into that big practice, right, it increases the enterprise value of that organization, and that small practice now becomes the value of the big practice, right? And the ultimate idea here is that private equity firm or publicly traded company or institutional investor will sell it in 3 to 7 years to a larger private equity firm or do initial public offering, right? And so there's big money in that, and this was fueled by low interest rates. The third part is, what are your competitors doing, right? If you are a large organization and you see another organization making these acquisitions, you're going to try to increase your market share as well, right? And so the only way to actually grow is to actually get bigger, right? And acquire smaller organizations. And by doing that, you increase your negotiating leverage with insurance companies to receive higher payment. And so those are the symptoms of what is actually going on in the United States healthcare space right now. Now, COVID brought on an interesting dynamic, is that we had a large retraction in economic expansion, and patients stopped going to the doctor, right, or to the dental office. And so during that time, a lot of physician practices and dental practices had a hard time keeping the lights on, right, to remain profitable, right? And it's been proven time and time in the research, the bigger you are, the more likely you are to succeed. Being a smaller independent physician practice is much harder to achieve these days.
Correct.
So what are you going to do to try to keep your lights on? You're going to sell your practice, right, to a larger organization, which can help you increase payments that you negotiate with insurers. And, a lot of these physicians currently in the state are baby boomers, and they're approaching their retirement, and they're going to want to sell their practice, right? And so this has created another dynamic of why you're seeing an increase of consolidation in the healthcare space. And what's also interesting is that the newer generation of physicians and dentists and oral surgeons, orthodontists, is they don't want to start their own practices. They want to work a 9 to 5, go home to their families, right, and not worry about hanging their shingle, on a building and building their practice from the ground up. As you know, Edgar, that takes a lot of work.
Correct.
So you're never actually off work when you have your own practice, right? And so there's this mental mindset shift that has taken place among younger generations. So all this is all this is no direct one of these is influencing, but it's a culmination of all of these things.
Sure. To brings actually to add to what you said is the students, also the recent graduates, they are graduating with a lot of debts. And as you mentioned that we were going to touch about the age population, but let's touch it on now. Baby boomers are in 2025, which is not that far away from now. I mean, we used to say 2030. It was like, wow, 2025 is 2 years from now. They are all going to be 64 and above, and they are going to be 25% of the population. We don't have a high rate of birth, so we are stagnating. These young fellows, as you mentioned, they are looking for a different way of life. We are not criticizing them, good or bad, but that's what they want to do. Baby boomers want to get out. They need somebody to buy them out. The young generation coming out, I had residents that came out with $800,000 in debts. And that's something people need to remember. Either it's a medical, probably less, dental, they do postgraduate, like my specialty periodontics, they come out with a lot of money. They can go to medical centers, they can do it cheaper, but nevertheless, there's something that's going to come out. 500, 800, whatever, that's a house. So adding to not want to have the commitment, add to it the baby boomers going out, add to that the birth rate is not catching up, our population is going to grow. That's why, as you mentioned it beautifully, describing the medical corporations or the dental corporations, the same thing, they are in the same boat with that. So having talked about the baby boomers and the aging, that's going to bring a whole different level, which was enlightening listening to you when I was in your class about the impact that they're going to give. And that's what I think we are not thinking about it. That goes back to the iron triangle. More access, more cost, that's quality. Some trade-off is going to happen. And that is what I would like you, if you don't mind, to talk about it and tell us what you think about this problem.
Yeah, so I'll say this, and just to elaborate a little more, is that, private equity firms are institutional investors. They essentially look for very fragmented industries to consolidate, right? Because I talked about that platform acquisition and then rolling up those small practices into that large organization, right? That's how you make the money, right? You roll them up and you consolidate them, because dental, I don't know if this is the correct term, but the dental space has been traditionally a cottage industry where you have a lot of fragmentation and you have a lot of dental practices that don't communicate with each other, right? And so by rolling them up into these large organizations, right, you've created more integration, possibly more coordination, right? But also at the same time, you might be also increasing access because you're making these larger organizations that can be reached to a lot more of a population. But you might also be increasing costs, because you have to remember these institutional investors have a fiduciary duty to maximize as much profit as they possibly can in typically 3 to 7 years, and then sell to the next private equity firm or other form of institutional investor. So that's the trade-off here, right? You might be increasing access, more patients are being seen, but costs are probably going to go up. The other issue too here is because they are trying, their fiduciary duty is to increase as much profit as they possibly can, right? Physicians might not like these types of corporate-based medicine organizations, because they're going to see more patients throughout the day, right? They might be generating more revenue for that organization, but physicians might burn out, right? And the quality of care might not be as good because you're seeing more patients and less allotted time. Remember, you have a fixed amount of time or a fixed amount of resources to see these types of patients. So there's this ultimate trade-off that takes place. And a lot of the evidence out there, not in the dental space, but in ophthalmology, dermatology, hospital-based specialties, right? What is you see increase in the number of patients, you see an increase in costs, but the quality of care stays the same or it goes down, right? So you have to ask yourself, from a societal point of view, what is the benefit of this, right? I'm not here to tell you one way or the other, but that's an ultimate societal type of question that we need to ask.
Yeah, I mean, that we as a society, we want more, high quality, but we don't want to pay money. And that's where this dichotomy is becoming actually more than dichotomy, it's trichotomy that is interacting with itself. And I want to go back a little bit about the importance of, we are training those young men and women to become dentists or doctors. It's actually a matter of fact, when I was running the program at NYU, we have a body called CODA, which is from the ADA, to certify the program. So I was through the certification, and they give you statements. And one of the statements, it's a very interesting one, the educational program must provide instruction to the level of understanding in the management of a periodontal practice. Understanding, not proficiency. So it's really the word that is a nuance. And sure enough, these kids comes out. I'm going to call them kids because, you know, at this age I can call them kids. So these young men and women come out. They are supposed to be trained to the level of understanding, not to a proficiency. But yet we were before throwing them in, building up a private practice from scratch, understanding how to match the budgets, control their expenses, provide care, don't be stolen by the people that work for you, and don't be ripped off by products. On a tight budget, they cannot expand in technology. That's what I'm trying to repeat what you said, but I want to give it as a lively. And yet when they were students, the people who were training them don't have any knowledge of how can they train them in management, especially nowadays. One of the reasons I left academic as a full-time in the dental, they don't want people to have a private practice. So imagine the blind is leading the blind. The poor kids are having somebody who's teaching them, graduating them. They've never run a practice in their entire life.
And I think you kind of hit the nail on the head there. You know, to start your own independent practice is a huge major lift and a large learning curve. And if you're going to start one of those start your own practice, it's probably not going to be profitable right away. And a lot of the time you're going to be just kind of figuring it out on your own. Whereas if you go to one of these large corporate practices, all of the back end managerial EHR functions are already taken care of, and you don't have to pay in and figure out how to do those things. Right. And that is a real advantage to one of these corporate practice models. Right. So, you know, the trade-off is, you know, you don't have to deal with those types of things, but you're probably going to have to see more patients than you would probably prefer. Right. And you're going to generate a lot more revenue for that large parent organization. And you're not going to get any equity. What you're going to get paid is a salary. Right.
Correct.
And that's the trade-off. But a lot of people in the younger generations are okay with that.
Correct. So, but that's a problem for the baby boomers. They want to retire and nobody's going to buy them. And that's why, but the biggest problem here is at the end of the day is the patient. We are always forgetting. We talked about the dentist, the doctor, the young ones, and when they retire. But the problem is this patients, they're going to lose their dentist to a corporation. The new dentist don't care. They have no buy-in to the thing. So the patient is going to suffer. Who is going to take care of me? Where is my special touch that I was used to it with Mr. Smith, Dr. Smith before, and now, you know, the young guy coming and works for somebody, and I don't know if he's going to do it. Yet some of them are motivated to really recreate the wheel and do it at a big price, huge trade-offs, or somebody like myself take the initiative and build something and help them grow in it and keep that ethics of it. So it's fascinating what we covered in this little time, and I hope that everybody is going to enjoy it. We are going to get close to the end, but I want to talk very quickly about the aging population again. The aging population for us is dramatic because these patients are living longer, which is great. They need a lot of medications. Medication interact with our care, creates a problem. God forbid something happens. This is a big expense for them, for the government, for everybody. The biggest issue that we are having, since we talked about the medical corporation and the youngs not, grasping it. So these patients needs a lot of care. They need a lot of communication with the dentist, with whomever else. This is lacking. And I see it as a clinician. I'm frustrated. They put them on these medication that can create a lot of problems, and they don't communicate with us. We are like a different body, although we were all the same. How can we incentivize those young guys that they're going to be the new generation? They're going to be who's going to replace my generation. It's funny. Nobody talks about my generation, Generation X. Like, we are the only one carrying the whole thing right now. Nobody talks about us. So who is going, the ones who are going to replace the X and the baby boomers? How can we incentivize them, both doctors, physicians, and dentists, to learn how to talk to each other? Is it connecting EHR altogether, electronic health records together is the solution? What do you think from economical point of view, your point on that subject?
I mean, it's a really tough question.
Well, you're the guy.
I think from like a high level, perspective, who knows really not much about, the dental field, even though I'm married to someone that is in the
Yes,
dental
indeed.
field. You know,
The whole family is dentist,
yeah,
actually.
the whole family. Yeah, my all in-laws are oral surgeons, general dentists, and
Yeah, yeah.
orthodontists. But what the one interesting thing is that Medicare doesn't provide, if we're going to talk about the above 65 population, Medicare
Right.
doesn't provide dental benefits, right?
Yes.
And there needs to be a financial incentive for physicians and dental professionals to talk to each other. There needs to be an introduction of some kind of payment model or reimbursement model where physicians and dentists receive additional compensation or bonuses for demonstrated interdisciplinary communication and collaboration. I mean, that's just one high level thing. This might be similar to how some pay for performance models work. That we've learned about and you've learned about in probably a lot of your classes, and rewarding healthcare providers for ensuring quality of care, especially when it comes to periodontal disease and its links to heart disease, right? And I also think that there probably, in that same vein, be some kind of shared liability. So like if both dentists and the physician share some responsibility for a patient's health outcomes, it can create an implicit incentive for both to communicate. And this is especially the case if there are legal or financial ramifications for adverse outcomes due to the lack of communication, right? Or lack of integration or coordination of care. How that would, be structured is beyond my reasoning, or probably for this podcast. But I think that those two things are very, very essential. And I think too, there probably should be some form of educational programs or some cross pollination across medical schools and dental schools. Right? I know that dental students take, first 2 years of medical school,
Correct.
but that's it, right? Maybe building or funding programs that emphasize interdisciplinary training for both upcoming and current healthcare providers, right? This would not only cultivate a culture of collaboration, but also provide the necessary knowledge to appreciate each other's roles, right? That's the first thing. And getting to your EHR thing, I mean, me, I've talked about in class about EHR systems.
That's why I'm bringing it up.
In theory, having EHR systems, interconnected can significantly improve the quality of care and potentially, reduce healthcare costs in the long run. Is that actually true? Mixed evidence, right? Those EHR systems are a boatload of money, to actually start up, right?
And to maintain them, yeah.
Yeah, exactly. And to maintain them, right? So, conceivably, right, that it can improve patient safety, efficient care through integration, coordination, and the most important thing here is better coordination. right? And then you run into the issue of, okay, if you have one EHR system at this one periodontics practice, and then they go see a physician at, some independent practice, those EHR systems may not actually talk to each other.
Correct.
So how do we create a system in which all of these EHR systems are agnostic? Unfortunately, the way the system is built, it's not built
To talk to each other.
purposely for systems to talk to each other.
Yeah, for proprietary reasons and so many other things. Yeah. It's interesting. I mean, we've talked about so many things in this time. I really want to thank you. There was one thing that I want to talk to, but I think I've overwhelmed you with the questions and with your
Oh, not
time.
at all.
I don't want to take too much of it. But I really appreciate it that you gave me this time and to cover all of these things that we did. It's really fascinating hearing it from an economist in healthcare, how much, and I hope all the listeners have learned a lot, because I have learned ton since I got into it, because we never understood these things. We never understood what goes in the mind of the governments and how the local. One thing that I learned the most with you is, this is one thing that we always blame the federal government, but in reality, healthcare is local. You just said it, and it is local. It's us, the states, the cities, whatever we are, to handle ourselves properly. So with that, I really want to thank you. I cannot thank you enough for making the time. It's always a pleasure to see you. I wish you all the best on your journey, and then we'll see you soon, I hope.
Thank
All
you so
right.
much, Edgar. It was a pleasure being on your podcast.
Thank you. Take care. Bye-bye.